So, hi everyone. Thanks for coming today. I'm Alice Fraser-Urquhart. I'm a research associate here at One Day. At the moment focusing on indoor air quality and pandemic prep. Um, I'll be hosting today's webinar. So, One Day, we're a non-profit that advocates for people who want to participate and have participated in high impact medical studies, particularly human challenge trials, otherwise known as controlled human infection model studies, where healthy volunteers are infected with the disease to test a vaccine treatment or to learn other important information. We were set up in 2020 during the COVID-19 pandemic, advocating for COVID-19 challenge studies. And since then, we've expanded to look at pandemic preparedness more generally, and a bunch of other interesting stuff. We've got a lot on with Hep C at the moment, a lot of US and UK policy research, and we also have an African chapter doing some cool work. We don't organize studies ourselves, but we do some organization with current and potential study volunteers. We do advocacy work with regulators, lawmakers, and other stakeholders across the world. We support and conduct research on vaccine policy, biosecurity, public health, and research ethics, and help elevate the voices of volunteers in public discourse. If you're interested in learning more or becoming a volunteer, you can sign up at our website, www.onedaysooner.org. You'll probably hear that a lot more. So I introduced myself and then the panelists. So I have been a volunteer myself. I've been in 2 challenge studies thus far. First one for COVID-19 back in 2021. And then last year for Imperial College, I was in a Salmonella challenge study, which is great fun. I've just graduated from my degree in biomedicine at UCL. And as I say, I'm currently working full time at One Day Sooner. So Jake Eberts is another 2-time human challenge participant. One for malaria and one is it? I can't remember. Oh, dysentery. Yes, famous.
Zika was the other one, not malaria.
Oh, Zika, not malaria. Sorry. I got my mosquito vector disease confused. Yes, Jake went very viral for his dysentery study. It was all over the internet. I think these tweets are still available. You can go back and search through them. Worked for One Day for a few years after that as communications director and is now on our board of directors. Who are great is a Baltimore-based designer who lives in a cooperative house that she bought with her 4 best friends, which is really cool. She began advocating for challenge trials early in the COVID pandemic, near the start of One Day Sooner, and recently participated in a flu exposure study through UMB Center for Vaccine Development, which is my favorite type of challenge trial. So yeah. And then Thomas Smiley is a materials testing specialist, which means, as far as I remember, he breaks stuff for a living, focusing on data collection and analysis. His involvement with bioethics and human challenge trials began as a member of the One Day Sooner volunteer group. And he's been involved in writing stuff for us, researching, and some public advocacy. So that's the panelists. And we'll start with the panel. So I've already talked a little bit about challenge studies, but just to be super clear, challenge study is a type of study design where researchers give volunteers diseases in order to test vaccines and treatments. They're a really good way of gathering information about products in humans early on in the testing process, particularly, for example, for vaccines. The only way to test a vaccine without a challenge trial in humans is to go out, give lots of people the vaccine, and wait for them to encounter the disease in real life, which can take a really long time and is very, very expensive. So a challenge study lets you get information about how a treatment works in humans in a controlled environment much, much more quickly in the clinical process for much less money. So it helps lower the risk of developing products. It also lets you, because you know exactly when volunteers have been inoculated, it lets you examine the early stages of disease much more closely. So before volunteers are even showing symptoms, which is functionally impossible to see in any systematic way in the community. So I'll ask my first question, so I can stop talking now, which is, why would you choose to participate in a challenge study versus another type of clinical trial? I'll put that to anyone on the panel.
I personally, I have a situation or I have a feeling. I also mentioned I'm a testing specialist, so I deal with data all day, and I am testing metals, breaking stuff, as it were, in which having functional data of real world tests and use cases really appeals to me. So my mentality is such that when you are trying to make models, when you're trying to understand, and when you're trying to re- extract as much useful data as possible, this type of testing is much more practical than any other testing, as Alistair pointed out. You can have all your parameters, all of the variables completely tailored to your needs, and to find that data incredibly accurately and very precisely. So in my head, because I started I started out understanding what these were during the COVID-19 pandemic, and I didn't know what to do. I said, what's going to happen? How can I help? What can I do? What is there for me to what way can I give of myself to make everything better? Because we were all in that situation where we all wanted things to be better. We all wanted an answer. And it seemed that this was a way to give of myself in the most practical and useful fashion, right? I say, I have a healthy body. We don't know what's happening under these circumstances. I can give myself and become of use scientifically in a way that gets us closer to our end goals. So why do that as opposed to any other way? Because it's faster, it is controlled, and it produces a great amount of really usable data.
Yeah, I also got interested in challenge trials during COVID-19. And what really got me interested in them was the impact. And I wanted to participate because it's not something that anybody can participate in. There's like people who aren't healthy usually are excluded from the trials um, just because it wouldn't be as safe. It was something where I had like by being able to be a participant, I had like an advantage in like doing something impactful that other people might want to do, but they might not be able to, or other people might not want to because of, anxiety or whatever. So it just was a way for me to help um, in a way that not just anybody could. Uh, so it felt more more impactful to do than a typical clinical trial.
Yeah, I think the common thread of impact is pretty appealing for a lot of people who volunteer, particularly the more altruistic side. It should be noted that challenge trials are just one piece of the puzzle, right? There's not with rare exceptions, you don't license a vaccine solely off of challenge trials or challenge studies, but they are compared to the gold standard of evidence, which is a large scale phase 3 in the real world, which can take a lot of time and a lot of money. And volunteering for those is a great option too. I know many people who have volunteered, for instance, the COVID phase 3s. Using the Shigella vaccine study that I did, for example, which Shigella causes dysentery. That was less. It was like 60 people overall across the entire trial, and so like the ability to kind of like see yourself as part of the puzzle and part of like the toolkit involved in investigating research into diseases that are really awful in the sense that like their global burden is really terrible, is really enticing. And that's one of the other reasons that I think I was drawn to these is, I think there are all sorts of medical trials you can volunteer and they don't have to be human challenge studies to be interesting or useful or, good for society. But the stuff that CHIMs or controlled human infection model studies, human challenge studies get used for are often diseases that are pretty neglected in terms of, global pharmaceutical spending and things like that, like malaria and, Shigella, or diseases that have disproportionate impact on really poor areas and underdeveloped areas of the world and cause a lot of suffering. And so, yeah, kind of echoing Thomas says, like feels like a concrete way you can do something.
Great, nice. Yeah. So, do you want to, everyone, again, do you want to talk a little bit about your experiences during the study? What things were like. There's people will have quite different experiences, I think, given the different studies they've been in. So do people want to talk a little about what actually being in a trial is like?
Yeah, I can start, I guess, with the two that I did really broad level. So I did two, one for Shigella, which, like I said, causes dysentery, and then one for the Zika virus. And so the Shigella one was super interesting. I saw an ad on Instagram. I clicked on it, signed up, and through pretty extensive screening and informed consent process, you don't just like let people kind of waltz in off the street and start the next day sort of thing. It was a pretty extensive. I signed up. Shigellosis, technically, is what it's called, is the bacterial form of dysentery. Is really, really infectious. And so they kept us quarantined in a hospital unit or like a hospital wing sort of thing up at the University of Maryland in Baltimore, which was a fantastic experience as far as getting dysentery goes. Round the clock, care and coordination by, a very highly trained staff. The principal investigator was someone who's, studied gastroenteric diseases like these type of, diarrheal diseases for his entire career. And so we took the little we all got randomized to take the vaccine, either a placebo, the fake vaccine basically, or the real thing. And then we all took the same little shot glass of basically of the bacteria in solution, which had been grown in a lab. Was like screened to make sure it wasn't super virulent or resistant to antibiotics. And then they waited and saw what happened, and they took our vitals, and we're constantly making sure we were okay as far as you can be okay with getting dysentery. Not everyone got sick. I got super sick. And I was really proud of it at the end of the day. And so that was my experience. I had a bunch of follow-up check-ins, lots of close attention to my health, both from a study, because of the importance of, the data for the study, but also just because, fundamental commitment to making sure that I was okay. And so that was a fun one. Like Alistair mentioned, I was tweeting about it through the whole process like a maniac and went viral. The second one I did was for the Zika virus. That one was a little more chill. Zika tends to not really cause a whole lot of it's not dysentery, we'll put it like that. And so Zika is very bad if you're a fetus, for example. But if you're a grown adult, it's a little less serious. But the harm it can cause to developing fetuses is really serious. That's why we would want a vaccine. This was a vaccine. This was a trial that didn't have a vaccine. It was to test to see if we could take Zika viral materials and reliably infect and safely infect volunteers. So we were one of the first cohort of males to be infected deliberately. That one was much more show up, hang out, stay inpatient. We did have a mosquito portion of it where we had to have mosquitoes in a little cup basically on our arms. And they were trying to measure how infectious mosquitoes that are present in Maryland world. This was at Johns Hopkins. Super interesting. But a lot of that was just hanging out, working remotely in this, dedicated unit at Johns Hopkins University. And having them collect data on and stuff like that on us. It was the range of illness there was much less severe than for dysentery. So those are my two experiences. Both of them were pretty convenient. The main things were transportation and getting up to these clinics for check-ins was a little bit of a challenge sometimes. You had to schedule it in, and dealing with bureaucracy in a large university research setting can sometimes be a little frustrating. But overall, they went very well.
I did a human exposure trial. So in my case, what they did is they had somebody come in. So they had about 20 volunteers in my cohort. They had somebody come in to the hotel that we were all staying in who had flu. That person, they tested to see how much they were shedding, what their viral load was, stuff like that. And then they exposed us to that person. And the study was partially to understand how flu spreads and how flu spread can be prevented. So in my case, I didn't actually catch the flu because I just nobody actually in my cohort caught the flu. But I think they found some interesting data overall from the study.
Yeah. I have spent a lot of time researching this type of study, and the things that they made volunteers do in 1980s is wild. They did studies where they made people kiss each other, total strangers. It's just awful, the things they've done. It's crazy. So I have.
It was in the 1980s and not anymore.
There was no kissing in my study,
no
so
no kissing,
80s were a different time.
The 80s were different. They really were. You would not be allowed to see that these days. So I've been in two, as I said, but the COVID one for me was wild, because it was in that time where the world had gone mad. So everything was like terribly urgent and also quite difficult. There were so many different groups working on this study. It was comparatively slightly riskier than in general. So most as a volunteer, most of the interaction was done with hVivo, which was the company which sort of carried out the day-to-day running of the trial, under the direction of Imperial, was how it was kind of structured. So there was tons of pre-screening and stuff to do from this study, and tons of waiting around while it got various approvals. So they actually first contacted me on the 23rd of December, to ask if I would come down to London for a screening on the 24th of December. To which my response was like, no, of course not. So I ended up going to a screening at the start of January, which was when the UK was in probably the most severe portion of lockdown that it had done in the pandemic. So that was all an interesting day. And then it was about 3 months from that point before I actually went into the study, which was in the Royal Free Hospital in London. It was in the the high consequence infectious disease wards, which meant very, very biosecure rooms. So yeah, it was an interesting experience. You kind of got shut up on day one, and then that was that, for 2.5 weeks. There were 2 days of kind of introductory testing, and then like 2 weeks of actual quarantine after. I would say it very quickly becomes quite monotonous. And they're very good about they get all the tests that they need to do done, which is like 3 or 4 times a day. They'll do various things. But other than that, it's kind of quite peaceful. You just are just kind of there. You don't really have much human contact, because all the other humans who come into contact with you, you're a massive biohazard to them. So you're kind of suited up in these enormous suits. So it's a slightly strange thing. There's not a lot to do. It's a bit like, the way I describe it to people is, it's a bit like if when you go on a holiday and you sometimes think, what would it be like if I just stayed in the hotel room, ordered room service, and watched the TV for the entirety of this 2 weeks? It's a bit like that. That's just what you do. So that was the COVID study. It was not a bad experience. And then I should also mention that I didn't get particularly sick. I got infected, but I wasn't particularly sick at any point. I lost all my smell and taste about day 9. That was the most exciting thing which happened, I think. I was like, wow, I really can't taste anything. Like, I know people said you won't be able to taste anything, but like, I really can't taste anything. It's wild. And then salmonella was very different. That was again run by Imperial, again in London. I actually lived in London for this time around, so it was quite a lot more convenient. That was all just, again, a bit more relaxed, with that particular pathogen. It's if you weren't directly showing symptoms, you weren't infectious. So actually, there was a bit of pre-screening again. I went there. They gave me it to drink the same morning I turned up. And then it was just kind of like, you're in this room, but as far as we're concerned, so long as you're not showing any symptoms, you're free to go and do whatever you want. Which was a perk that I didn't really take advantage of, because about 12 hours in, I began to feel funny. And then like the second morning I was there, I was like, yeah, I'm going to bed. And then, yeah, I was really quite ill for the rest of the duration of that study. So yeah, it was an interesting experience. A lot of it just involves being in the same place for a long period of time. I'll wrap it up there, and hand over to Thomas if he has anything to say, and if not, we'll move on.
Yeah, primarily I was in, just for clarity, in a norovirus study to determine the optimal dosage for infection. So again, a little different than some of the other ones, but basically this was a slice of the experiment in which you saw how much did it take to get any cohort reasonably and effectively experiencing the symptoms of the virus. So that was what they're trying to determine. So norovirus, what is norovirus? It sounds, we'll use all these words and say these big fancy things, it's food poisoning, essentially just food poisoning. And so that's part of what I think of when I go for it. Well, what was I going to do? I was going to try to get food poisoning for a week. I just, hung out for a week. And that's as fearful as some of these things can sound, because, Alistair went for COVID, and Jake went for dysentery. Wait, not dysentery. No, yes, dysentery. Yes, okay. I was which one you didn't do. It puts this great fear into you, and mine was just for food poisoning. But again, I loved it because it was such a useful thing. It is a very common disease in the world. So like, hey, let's actually be of use. But like Jake said, we got there. Said this is what the process is going to be. You're going to stay up on Sunday night, and you are going to drink the shot, the little shot of water with all the bad stuff in it. Pounded it back, and then you just hung out for a week. We studied you. We made sure that your bowel movements were this. See if you had any vomiting. Checked all those parameters. It's basically just being intensely studied for these factors. Realistically, I was not required to do anything more than, like I was saying, just kind of be for a week. It is a little limiting because, you're just kind of cooped up in one big main dormitory. Had my own room. We had common rooms, but, for the most part, the most entertaining thing to do was just to kind of be in your room and watch TV and what. To Jake's point, I live in the middle of America, very car-centric culture, car-centric area, in which it's not actually that bad to do the follow-up visits, because after you're out and after they get you all, they want to, do follow-up visits. So you get your sense of freedom back after the week. The follow-up visits are a little bit, you have to schedule them in and make sure you get there. But because I'm in a car-centric area of the United States, it's very easy. So my entire time I was participating and doing this, it was literally just like hanging out in the dorms for a week. I made a big thing about, this is going to be, I'm going to do nothing. I'm going to go there and play Nintendo Switch and get paid for it, essentially. And I did. That said, some of the cohorts did experience all the symptoms and got very ill. I happened to not get ill, but that's part of the process. We're actually determining whether or not data works. So, hey, that was not enough. The dosage was not enough, but essentially just hanging out for a week.
No, thanks. Yeah, another question is like, are there any factors that might particularly dissuade people from participating?
Time is such a incredibly salient point on that. I know I have not participated in more. Things have come across my desk every once in a while, and for me, that has a job where I'm actively in a laboratory on site, taking a week off from work is quite a challenge. So that kind of prevents me from doing it. And as Jake and Lahua, who are in a much less car friendly city or area, I guess, metro, travel might be, for me it is not, but I can understand why booking planes and booking overnight stays and booking all those things might be kind of a problem.
I had somebody in my trial who lived in New York and was doing the trial in Baltimore. And so they had a pre-trial thing that she had to get to and then go back to New York. And then the trial itself, she had to get to and go back to New York. And then they had a post-screening, like 3-month check-in afterwards that she had to, so transportation can be an issue if you're not local. I definitely want to second what Thomas said about time, because when I did my trial, it was 2 weeks and you weren't allowed to leave and you weren't allowed to see anybody. And I really struggled to find 2 whole weeks where I didn't have some hard commitment that I absolutely had to be present for. And I don't have kids and I don't have an in-person job. So I can only imagine if you do have those things, how difficult it would be to have an uninterrupted block where you can be quarantined. And the other thing I was thinking was I do have some friends who have medical anxiety, especially after COVID. I think medical anxiety really picked up around that time. So those are people who I would never recommend to do a challenge trial because they get really freaked out if they think they might be sick, and the whole point is to get sick. So
I agree. Timing, it takes a lot of time. And it's totally normal to be like, I don't want to get, malaria. Like that's a very valid reason. So like the base level, like it will be uncomfortable, sometimes even painful, and like involve, giving up a lot of privacy for a while. Every trial is different. Who wasn't allowed to talk to other people because of like cross-infection concerns. I could hang out with the dysentery and the Zika guys. But it just really was, it depends. But there's, social isolation potentially for especially respiratory diseases. It's really trial specific. Some trials like malaria ones, often you're outpatient for most of it. So it really is context specific, but either way, like the time commitment and the discomfort and pain that can be involved is, I think, two of the main factors that would discourage that you should take into consideration for, thinking about joining a study.
Yeah, I'll second that. Also, and I was like second Jake's point. Yeah, you will like you might feel very ill. My December when I was studying, I felt absolutely awful. Yeah, it's really really bad. So yeah, that's another thing you might feel ill, and if you're like me, you won't enjoy that. So we'll move on a bit now. So maybe Jake Jake and I can tell you, maybe we'll start with Jake because I've been doing a lot of talking. Can tell us a bit about what diseases are commonly investigated in CHIMs.
Yeah, I went and pulled up actually the paper that One Day Sooner sponsored that was published in Clinical Infectious Diseases in early 2023. And that was a systematic review of human challenge studies that have been published up to that point, and like really covering mostly just through 2019 or so. And so recently, the most common ones are like malaria, influenza, rhinovirus, which is like kind of a common cold virus. Then you have functions like E. coli, respiratory syncytial virus, RSV. The recently licensed RSV vaccines for seniors involved human challenge at one point. Salmonella, norovirus. There are a couple other ones, and then you have newer ones like COVID. Famously came out. That's kind of part of the genesis of One Day Sooner. And there are discussions for other ones too, like hepatitis C, which is also something that One Day Sooner is like really enthusiastic about. Those have not begun yet. So that's like the broadly, malaria is a big one. These are very like geographically isolated, which is to say there are only so many places in the world where you have centers that run human challenge studies, probably like no more than like what, 2 dozen globally, or so, at least with any regularity. And it depends, like some of them have expertise in respiratory studies, or some of them are really focused on malaria or exclusively focused on malaria. So it just depends. But those are some of the big ones.
The only thing I'd add to that is also there's a lot of RSV studies and influenza studies in particular are done for commercial reasons, companies testing products, and then other diseases tends to be a bit of a mix. And a lot of times it's like you have to figure out how to use the model, figure out what doses you're using before you can use it to test products. So for a lot of times it's like a public health push to develop a model, and then it might get picked up commercially later down the line. So it can be a kind of, for lots of other kind of bacterial pathogens, for example, it can be a kind of mix of public and commercial use depending on where you are at the kind of product development cycle. And then maybe we could talk a little bit more about like why they've become accepted as a more mainstream form of medical research over the past few years. Put that to anyone, and if not, I'll talk about it.
Yeah, I can venture to guess. I feel like actual scientists running these would be probably the best situated to answer, but I think you kind of reach a critical mass at some point where it becomes clear that like there's infrastructure available to do these sort of things that can be, widely accepted by society when done ethically and carefully, as is the case. And you have the expertise as well that kind of grows as people, graduate students take part in these, in this research. You kind of increase the number of people as sort of a snowball effect. Still very limited by the number of like facilities that have, for instance, biosecure. For some studies, the biosecure facility requirements, the expertise, institutional review boards or research ethics boards that are kind of okay with that, like who are familiar with it. But I think broadly, it's my sense is that there's the kind of like, as it's been recognized that they can be done, safely and effectively for a range of diseases, it has kind of created this sort of small renaissance of them in the past decade or so, where positive public publicity and awareness, and COVID being part of this as well, has kind of increased the willingness to use them as a tool, or to consider using them as a tool worldwide.
Yeah, a couple of things I'd add is that I think there's a kind of a more like an increasingly more modern ethical acceptance of human effects studies. I think they like human effects studies that have a long and sometimes quite potted history. I think there's been like some perfectly rational ethical pushback, particularly kind of towards the new millennium. But I think particularly in the UK, which is very well situated and does a lot of challenge studies, that not only the kind of the number of studies, but the kind of diversity of different study designs has been broadening quite a lot in the last few years. So, for example, this kind of LaHua's like influenza transmission study is like not many of those have been licensed over the last few decades, or approved rather in the last few decades. So it's like interesting to see those types of studies expand, and there's plans for like more of that kind of studies, which is cool. So I think that's like another thing. It's this kind of more modern ethical and scientific understanding of like how channel studies actually fit into kind of modern research practices and processes. Yeah, so another kind of question for everyone is like currently what's being done well with challenge studies, and what can be done better, and kind of like how they are.
I'd be curious to hear LaHua's and Thomas' opinions based on just like what went well and like the operation at the operation level of the trials that you guys were in.
I think the things that went really well were, I guess after the first couple of cohorts reported being really bored, being exposed to this person who had flu in like, a room for 12 hours a day, but not having anything to do. The team really upped their game entertaining us. So we had like karaoke and yoga and dance, just dance, like video games, and tons of board games and puzzles and stuff like that. And the study research team were acting kind of like activities directors or activity directors, like being like, okay, now what do you guys want to do? Like, let's like setting up the next activity. I think that's something they figured out after a couple rounds, or after at least a round. The thing that didn't go really well operationally was the food. Um, they had everybody eating the same food because that's um, a factor. If somebody gets sick, but they were eating different food, then like could that have exposed them? So everybody had to eat the same food, but like they didn't adjust the portion size for the metabolism of the person eating it. So some people were hungry and some people had way too much food. And also they didn't really let you pick what food it was. So it was pretty so-so.
I am. Oh, good. Okay. Thought you froze. Um, I found my time to be incredibly smooth. The way in which I was onboarded was incredibly clear and concise. They made a lot of accommodations to make it work for me. I've done a little bit of studying and understanding about what goes on in other cohorts and other studies, and I will just say I think I got one of the better ones. I don't have a lot of data points to kind of to say either way, but one thing that was very important to me, because I've been working one day sooner, even before I started my challenge trial for norovirus, was that I'm aware of what I need to understand, what I need to know, how payments are going to work, what you need of me, what your expectations are, what your goals are. And every piece of information that came across my desk made that clear and very precise. There were no gaps and no blind spots in my information. And I think that that is something that, as I've read anecdotally from a few places, that can be a problem. I wanted to be aware of that, but from the transmission, the chain from the doctor that was doing the entire study all the way down to every participant, we knew everything that was going on, and I cannot stress how important that is within a volunteer's scope. So that was great to me. I had great facilities. I know sometimes facilities matter to you. Anecdotally, around one day sooner, there was a challenge trial in, was it I think it was in Germany, but somebody had to bring in a bike, an exercise bike. Wait, what did, my goodness sakes, you got to bring in everything, yet some people couldn't get, lip balm sent to them, whatever. But my facilities were great. We had, movies and entertainment and workout room, and we had space. It was great. I quite frankly found that I was really happy with everything that could be done. It was maybe I wish that, and I kind of answered this in the chat. I wish I could have gotten a little bit more follow-ups on what they're doing with the data, and to kind of give me those good little feelings on the inside. Oh my goodness, they're doing this. They're sending your package over here. When you click the pizza button, and they say, we're making your pizza right now, we're putting the toppings on. It would have been nice to kind of go, hey, Thomas Smiley's data is going here and going there, and you get all the, this is helping this person. That would have been cool. But it does make you feel better if you have that, so that'd be nice. But outside of that, mine was fantastic.
Yeah,
Yeah,
I'm sorry, go ahead.
oh, sorry. I was just going to second that. It would be nice to know what the status of the research was after you participated, to get like a looped in on if they publish a paper or anything. That's all.
Yeah,
Yeah,
I've had trial teams check in afterwards. So we had a couple of like presentation sessions for the COVID stuff, which is cool. It was like exactly that. Like, this is what happened, which is nice.
yeah, I think that actually needs to be improved pretty massively. Is there's this disconnect between, um, you know, what you've done, like the study participants, and what happens to the data later on. To highlight one example, we know someone from the Wendy Cedar Network who was involved in the human challenge studies that were done to license what is now the vaccine for malaria, new vaccine for malaria being rolled out right now in Africa, which could very feasibly save hundreds of thousands of lives. And if that person did not work with us, they would not know about this, right? Unless they happen to read the news and connect the dots, because in my study, the vaccine for the Shigella study was SF2A-TT15. Like, it's just like a bunch of acronyms and numbers, and you're not going to track that in the news. And so I think that is one thing that studies tend to drop the ball on, is like, it doesn't take a lot of effort to do a mass email and say, hey, by the way, this is what happened with this. That is something I think most sites drop the ball on, unfortunately, especially considering how relatively straightforward you would think it is. You kind of have to do a little bit of work. And if you like go out and proactively email people, they're usually happy to respond, but they just kind of assume that like most people don't care, which may be the case, but I think it's like, again, probably low effort way to just be like, by the way, this is what happened, even if whether or not it's successful, like, whether it's successful or not, if the Shigella vaccine fails, saying, paragraph 2 being like, thank you so much for your contribution. Failure is fundamental. This is the fundamental thing that drives science forward. And this vaccine failed, and we're going to move on to other things now. And your participation was critical in making sure we didn't expend more resources than we needed to on something that didn't work, that sort of thing. So yeah, I think that's actually one thing that needs to change. And is relatively easy, I think, to change overall.
Nice. Yeah. I'll ask this question now, which is like, do people want to talk a little bit about how they thought through risk, like the risks themselves, how they weighed that up before studies?
Yeah, I was actually typing our response to this one. I can say that in both studies that I did, the risks were very clearly advertised, both in terms of, and risk here being like, here are the things that like could happen to you that will be uncomfortable or painful or bad, diarrhea, whatever. And like here, like do we think there are long-term risks to your health? We were screened for, a gene, for instance, associated with, kind of chronic sequelae, chronic complications, post Shigella infection, to make sure that we didn't have it. to have that gene or the predisposition. And so I had a pretty high trust of the research ethics and oversight systems at the universities I participated at. I would, have a pretty high trust in the medical system in general. And so I was relatively confident, all else being equal, that like, some horrible Frankenstein unethical experiment would not have been conducted in the first place. That still didn't mean I didn't, just write off the risks. Asked a lot of questions of the study staff. The informed consent documentation we received was really extensive. We had to take quizzes and be like, list 3 things from this document that like could happen to you as a result of this study, that sort of thing. And I thought that was pretty sufficient. Ultimately, like you can't really like encapsulate the experience of, getting dysentery on purpose in like, a 10-page Microsoft Word document. But I thought it was pretty decent, introduction and helped me kind of understand. There's like, presentation by the PI, the principal investigator who's running the study. So yeah, I think that they're like thinking of the risk, is something that was like, what, I get sick. I'm confident this disease will not kill me. You don't do human challenge studies for things like Ebola or HIV that are like incurable, terminal. You don't even do them for, COVID was really at the edge of kind of the window there, because even though for the vast majority of young people, it's obviously not fatal. Like even that like small chance was still quite controversial. And so you don't, again, do it for things like Ebola or even something where, maybe there's only a 10% chance of, at a, serious fatal complication. That'd be way too high. So I think that that's how I kind of felt about risk, because like the mortal risk is low, very, very low, enough that I'm willing to take, to put my, health in the hands of these trained medical professionals. So risk to myself was more often just like, how uncomfortable is this going to get? And that's something you can, predict, right? There are people in my cohort who didn't get dysentery at all, despite us all taking the same dosage of the virus or this bacteria. So yeah, there was just a range there.
Mm-hmm.
I think the next question in the Q&A actually segues into the other one, like we plan on talking about, which is compensation, which I can cover pretty briefly for sake of not rambling or lecturing, because this is something that was in my portfolio when I worked at Wendy Sooner. So one of the honest attendees asked like how clinical teams attract volunteers, and whether it was advertised as paid opportunity, and whether we saw volunteers who were primarily there to receive money. So the first answer is like advertisements happen in a bunch of ways. Often you'll have like an internal mailing list of people who have signed up. They've seen advertisements. Like I said, mine for Shigella was on Instagram. Wendy Sooner advertises these to people on our mailing list. You'll see flyers on college campuses. Oftentimes you'll see places like outsource it to what are called contract research organizations, which do advertising campaigns. Particularly among people who participate more regularly, you do see people who are primarily motivated by money. Like that's a thing. That is true of human challenge studies. That is true of any form of like kind of paid healthy volunteer medical research. And in a lot of these cases, they are explicitly advertised as paid studies. Sometimes they don't tell you how much they're paying until you like call, which I actually think is pretty frustrating. The underlying logic of that is like people worried about what's called undue inducement, or undue influence of people who are kind of, the idea, which makes sense when you think about it at first. It's the idea that, someone will be so tempted by the money that they kind of lose all rational sense of ability to assess, rational risk and reward. I think both empirically and my experience as a volunteer, empirical research, theoretical research, and my experience as a volunteer ultimately show that kind of answer, that kind of like concern, while well-meaning, is a little bit misplaced. People go through an informed consent process. These studies are already vetted. It's not just like someone off the street being like, hey, do you want to put your hand into a wood chipper for $5,000? Like they're done for a legitimate scientific reason. And so that kind of segues into the question of like how compensation is set. Depends massively differently based on institutions, even within the same, or even across time within institutions. For a human challenge study, you're going to typically see low thousands of dollars. I think the highest I've seen was the equivalent of like 13,000 US dollars. And that was a double challenge where you and actually there's one in the United Kingdom that's running that's like a massive year-long, get malaria multiple times sort of thing, and like to come in for like 100 visits, and that's like about like 10 or 11,000 pounds, I think. And so that's at the very high end. Money is definitely a big part of it. I was pretty upfront when I did my study that money was a huge part for me. I was like, I'm really happy to help the world and get dysentery on purpose. I am not going to do it for free. I had to take time out of my schedule. It was uncomfortable and painful. And so for me, like the money was like first and foremost a sign of like respect. It's like you're doing something for the greater good. And yeah, so compensation is set really kind of based on, the nice way to say it is like based on deliberate consultation and so on and so forth. Frankly, oftentimes it does feel a little bit like vibes, and the vibes are we don't want to pay too much money or look like we're paying too much money because that's scary. I think that that's a little bit misplaced and misguided. I think that again, concern over paying too much is well-meaning, but is often really regressive and doesn't actually protect participants. Like someone like me, middle-class guy from DC, if you pay me $5,000, that might not be enough. But if you pay me $10,000, maybe that's enough. But $5,000 is always going to be maybe enough for someone who's has lower socioeconomic status than I do. And so if you